Hello guys, in this part I want to talk about electrocardiogram or ECG or EKG of our heart and also the cardiac cycle and the factors which affect the EKG, the cardiac cycle and electrical events of our heart. Electrical changes within the heart can be detected during a routine physical examination by using electrodes attached to the skin. Usually we put electrodes on wrist, ankle, and 6 separate locations on our chest. These electrode signals are collected and charted as the electrocardiogram, as you see in this picture. We call it ECG or EKG. This is a common diagnostic tool, and the instrument which used for this recording is called electrocardiograph. As you see in this picture, we have different waves and different parts in our EKG. The first part which you see is called P wave. P wave can show you the depolarization or contraction of your atria. The next wave is called QRS complex. The QRS complex can show you the depolarization or contraction of your ventricle. And after that, we have the other wave, which we call it T wave, and the T wave can show us the repolarization of the ventricle. So depolarization of the atria, depolarization of the ventricle, and a repolarization of the ventricle. And in this picture, you cannot see any wave for repolarization of the atria. The time of repolarization of the atria is located exactly on the time of depolarization of our ventricle. Because the wall of the ventricle has more muscles and thicker than the wall of the atria, the wave of QRS is much more stronger than the P wave. Because of that, it can overlap it and we cannot see the wave of atrial repolarization. So, as I told you, the P wave can reflect all electrical changes of atrial depolarization, which originate in our sinoatrial node. The QRS complex are electrical changes associated with ventricular depolarization, and at this time atria automatically go to repolarization. And the last one is the T wave, all the electrical changes associated with the ventricular repolarization. Again, in this picture, you can see P, QRS complex and T, and after that we have the other heartbeat, which is P, QRS and T. First, I want to show you one heartbeat here. As you can find in this picture, each heartbeat starts from the start of one P to the start of the next P. So between these two red line is one cardiac cycle or one heartbeat. In each heartbeat, you can see first the atrial depolarization as the P wave. After that, we have QRS complex, which is the ventricular depolarization, and T wave as the ventricular repolarization. And we have a time here which our heart is in rest. This blue line can show that your heart is in rest, no contraction, no relaxed, no changes in your heart, and after that the next P starts again. When we check the electrocardiogram, you can see different segments and intervals here. And I want to talk about these intervals and segments for you. The first thing which you can see here is our PR interval. Look at this PR interval. The PR interval is a start at the start of P to the start of QRS complex. This time, let me draw R here for you. This time is called PR interval. What happened during this time? In this time, our atria go to contraction, which we have it in the P wave, and after that remaining in contraction in this plateau line. So we have a time which when your atria is completely contracted and remaining in contraction. And this remaining in contraction can be detected by this segment. We call it PQ segment. So PQ segment is the segment when your atria is remaining in contraction. The next interval which we have here is called QT interval, and this is the QT interval. The QT interval starts at the beginning of QRS and end at the end of T. What happened during this time? During this time, first in the QRS complex, your ventricle go to contraction, then your ventricle remaining in contraction, and after that, your ventricle starts to become relaxed. So the QT interval can show you all the events which happen in your ventricle. Contraction, remaining in contraction, and after that relaxation. And we call it QT interval. This PR interval and QT interval is very important. The unit of these intervals are seconds. And we should have a range for a normal range for PR interval and QT interval. If this time is longer than normal, it means that our heart beats slower. If this time is faster than normal, it means that our heart can beat faster. And all of them, bradycardia or tachycardia, can be a problem which we have for our heart. And the other thing which you need to know is this ST segment. The ST segment is the time when your ventricle remaining in contraction. And again, the time of PQ segment and ST segment are very important when we want to describe this EKG. I will talk about it in the lab for you. So here you can see the waves and segments. Two segments between waves are in plateau phase, and they can show you the remaining in contraction of your atria or ventricle. Here you can see, let me draw it for you because it doesn't label in this picture. From here to here, we have a PQ segment, and it's associated with the atrial cell plateau. Your atria are contracting, and it's very important. And the other one is the ST segment. As you see here, it starts from the end of QRS and end at the start of T, and we call it ST segment, and it's associated with the ventricular plateau. Your ventricle are in contracting phase in this time. And as I told you, the intervals are PR interval and QT interval. The PR interval is the beginning of our P wave to the beginning of our QRS complex, from atrial depolarization, beginning of our ventricular depolarization, time to transmit, and this PR interval is the time to transmit action potential through entire conduction system. And the other interval is called QT interval. It's time from the beginning of our QRS complex to the end of T wave. It reflects the time of ventricular action potential, and its length depends upon our heart rate. And when we have changes in this length, it can make tachyarrhythmia for us. Tachyarrhythmia means our heart can beat rapid, and the beat is irregular. We don't have the same timing for our intervals. So you need to know all of this definition. What is the definition of ST segment? What is the definition of QT segment? PQ segment. The other one is the PR interval and QT interval. When we use EKG, the physician can determine if the conducting pathway is abnormal, if the heart is enlarged, if certain part of our heart is damaged, and they can figure out the chest pain. The EKG is a common diagnostic tool that is used in physical exam and after surgery to detect many changes to the heart, including abnormal heart rhythm, hypertrophy of the heart, low blood flow to the heart, which we call it ischemia, and damage to the heart from myocardial infarction or high blood pressure. This is very effective tool in diagnosing many conditions, but it cannot detect all the abnormalities. And it's one of the several diagnostic tools for cardiologists to use and diagnose different problems for the heart and start doing their treatment. And cardiac arrhythmia is any abnormality in the electrical activity of the heart. We have different problems, and you don't need to know about that. Just you need to know the definition of arrhythmia. Now, I want to talk about the cardiac cycle. The cardiac cycle is all the events in our heart from the start of one heartbeat to the start of the next one. If you remember the previous EKG, it's like this. We have P wave, QRS complex, and T wave. And after that, we have the next wave, which is like this. So the time of start of the first P to the start of the next P is called one cardiac cycle. In this cardiac cycle, you know that we have P wave, we have Q, R, S complex, and after that we have T wave. It includes the contraction and relaxation. And from now, instead of contraction, we use the term of systole, and instead of relaxation, we can use diastole. Contraction increase the pressure. When your heart go to contraction, the pressure which we have on the blood increase, and relaxation can decrease the pressure. When your heart go to relaxation mode, the pressure on the blood decrease and decrease. The blood move down its pressure gradient. You need to know that all the times. The blood can move from the place where the pressure is higher to the place where the pressure is lower. Imagine that this is your heart. And you have these different chambers: right atrium, left atrium, here, right atrium, left atrium, right ventricle, and left ventricle. When your atria go to contraction, the pressure here increase. At this time, your ventricles are relaxed, and the blood can easily come down from atria to ventricle, from the place where we have higher pressure to the place where we have lower pressure. And the valves ensure that the flow is forward. We should not have the back flow of the blood. If we have a back flow of the blood, it means that we have valvular insufficiency. Our valves cannot close completely, so we have problem for back flowing of the blood. So the cardiac cycle is all the events which happen in our heart from the start of one heartbeat or one P wave to the start of the next heartbeat or the next P wave. The ventricular activity is the most important thing which can make force and movement of the blood. The ventricular first we have ventricular contraction. The ventricular contraction can increase the ventricular pressure. When our ventricle go to contraction, the AV valves are closed and the semilunar valve become open with a very short delay. And the blood go to pulmonary trunk from the right ventricle and to aorta from the left ventricle. The next happening is the ventricular relaxation. When your ventricle go to relaxation, the pressure in your ventricle decrease. At this time, the semilunar valve become closed, no pressure from below to keeping them open, and the AV valve become open, no pressure pushing them closed. So when your ventricle go to contraction, your AV valves are closed and your SL valve are open, and when your ventricle become relaxed, your AV valves are open and your SL valves are closed. One cardiac cycle includes all events associated with one heartbeat. When your heart rate is 75 beats per each minute, your cardiac cycle lasts about 0.8 seconds. So each cardiac cycle is less than 1 second when your heart rate is 75 beats per each minute. One cardiac cycle consists of contraction or systole and relaxation or diastole of both atria and rapidly followed by systole and diastole of your ventricle. In this 8/10 of a second, we have all of this happening. We have electrical changes, we have pressure changes, we have heart sound, volume changes, and mechanical events. And now I want to talk about all of these different processes in each heartbeat. As cardiac cycle begins, all chambers of your heart are in their resting mode. It's important. So at the beginning of each cardiac cycle, 4 chambers are at rest. The blood returning back to both atria. Do you remember to the right atrium, we have a superior vena cava, inferior vena cava, and coronary sinus. So it means that all the bloods from the parts above our heart are collected by superior vena cava. All the bloods from the lower part of our heart are collected by inferior vena cava. Look at here, this is your heart. This is the superior vena cava, which bring the blood back to the right atrium. Here you have the inferior vena cava, which bring the blood back again to the right atrium from the parts which are lower than our heart. And here you have the opening of coronary sinus, which can bring the blood from the wall of the heart itself to your right atrium. And also we have 4 pulmonary veins, as you remember, which return oxygenated blood from right, and let me draw 4 of them here for you. Right and left lung to the left atrium. So the blood returning back at that time. And in this time, these AV valves are open, the valve between atria and ventricles, and the blood can easily pass through the atrium to the ventricle, because at this time, the atrial pressure is more than the ventricular pressure. During this time, the semilunar valve are closed because the pressure in the ventricle is lower than the pressure in the atrial trunk. So the valves are closed. Now I want to start talking about atrial systole for you. The atrial systole, which lasts about 0.1 second, starts by depolarization of our SA node. The SA node become depolarized and the atria go to contraction or go to systole. During this time, the AV valve are open and the blood can come down from atria to ventricle. Let me draw this picture here for you. Imagine that this is your heart. Now, we have depolarization of SA node here, and the wave of depolarization can spread in all over the atria. Both atria and your both atria go to contraction. The AV valves, right AV valve and left AV valve are open, and by contraction of the atria, about 105 milliliter of the blood can come down to the right ventricle and 105 milliliter can come down to the left ventricle. After that, the auricles, which are the blind sacs which are suspended to your atria, go to contraction. Contraction of the auricle, about 25 milliliter of blood can come down to ventricles. Now, how much blood do we have in each ventricle? First, we have 105, and after that we have 25 milliliter. So in each ventricle we have 130 milliliter of the blood. So 130 in right and 130 in left ventricle. So you can see it here. Now you have 130 milliliter of blood in each of your ventricle. And in this time, your ventricles are in relaxation mode. They don't start their contraction yet. So this volume of the blood, which we have in our ventricle at the end of atrial contraction is called the end diastolic volume, or EDV, and the amount of EDV is 130 milliliter. After that, our ventricle starts going to depolarization. So during the atrial systole, which I will show you the pictures later, we have depolarization of the SA node. Then we have the systole of the atria, the contraction of the atria. You see that the amount of blood can come down from the atria to ventricle, and this amount is 105 milliliter in each side. Then the auricles go to contraction and 25 milliliter come down to right ventricle and 25 come down to left ventricle. This amount of blood is called EDV, end diastolic volume. And this time your atria go to contraction completely and your ventricle is relaxed. Because of that, we call it end diastolic volume. And then our ventricle go to depolarization. After that, we have a ventricular systole. The ventricular systole lasts about 0.3 seconds. In this time, our atria go back to relaxation. During this time, we have a ventricular depolarization. Our ventricle go to contraction. During this time, the AV valve are closed and the SL valve are closed too. So your ventricle go to contraction, all the valves are closed, and the blood cannot go anywhere. This step has a specific name. We call it isovolumetric contraction. Iso means the same. It means that although we go to contraction, but the volume of our blood doesn't change because the blood cannot go anywhere. And when the pressure of the blood increase and increase in our ventricles, the pressure can open the semilunar valve and the ventricular ejection can happen. When we have ventricular ejection, about 70 milliliter of blood go to aorta from left ventricle and 70 milliliter of blood go to pulmonary trunk from the right ventricle. Do you remember we have 130 milliliter of blood? Now 70 milliliter go to each of our arteries, and the result is 60 milliliter. So 60 milliliter of the blood remaining in the ventricles. This 60 milliliter has a specific name. We call it end systolic volume, or ESV. The ESV is the amount of blood which we have in the ventricles after ventricular contraction and blood ejection. And then our ventricle start going to repolarization. The ventricular ejection. The ventricle continue to contract, so the ventricular pressure rise above the arterial pressure. And I told you that all the times the blood can move from the place where the pressure is higher to the place where the pressure of lower. So when the pressure of the blood in the ventricle increase from the pressure of the blood in the arteries, then the blood can easily go to the arteries. The semilunar valve forced open by the pressure of the blood, and the blood can move to the arterial trunk. This amount of blood which moved to arterial trunk and ejected by the ventricle is called a stroke volume. So the stroke volume is the amount of blood ejected by a ventricle. The end diastolic volume is the amount of blood the end systolic volume, which remain in the ventricle after contraction. And you know what is the meaning of end diastolic volume. The end diastolic volume is the amount of blood which we have in the ventricle at the time of ventricular relaxation and atrial contraction. And you see that the ESV or end systolic volume is equal to EDV minus a stroke volume. And I told you that the EDV is 130. The stroke volume is the amount of blood ejected by ventricle to each arterial trunk is 70. So when you subtract these two numbers, you have ESV, or 60 milliliter of blood which remain in your ventricle. So again, in this picture, you can. I want to show you the pressure change. The stroke volume is the amount of blood which ejected per beat from each ventricle. Pay attention. These two words are very important. Ejected per beat from each ventricle. And EDV is the amount of blood in ventricle after diastole, and ESV is the amount of blood in ventricle after systole. And the other equation which you can have here is the stroke volume is equal to EDV minus ESV. 130 minus 60 is 70 milliliter. This 70 milliliter is the amount of blood which goes to your aorta or pulmonary trunk. And in this graph you can see it. This is the end diastolic volume. The end diastolic volume is about 130, and the end systolic volume is 60. And the difference between end systolic and end diastolic is called a stroke volume. And after that, we have relaxation period, which is about 0.4 seconds. The ventricle and the atria are in relaxation mode. All valves are closed, and we have relaxation, which we call it isovolumetric relaxation. It means that we are in relaxation mode, the valves are closed, and we don't have any change in the volume of the blood in the chambers of, in the ventricles, actually. At this time, the atria are filled with the blood, and this filling of the blood can make pressure on the AV valve. The AV valve become open, and the other heartbeat start. I want to tell you something on this picture. I can show you this one. Look at here. In this picture, you can see the P wave, the QRS complex, and T. You know that here it shows us the atrial depolarization and contraction. Then you see that your atria go to remain in contraction for a little bit to send all the blood to the ventricle. After that, we have QRS complex, which is the ventricular contraction and ventricular systole. And at this time, our atria going to relaxation. During this time, your ventricle remain in contraction, which we call it isovolumetric contraction. And then our ventricle become relaxed, and you can see it by T wave. All of this happen in 0.4 seconds. Let me write it here for you. They happen in 0.4 seconds. So all the happening which we have in our heart happen, contraction and relaxation, in 0.4 seconds, and the relaxation period of our time is 0.4 seconds. So contraction and relaxation of atria and ventricle happen in 0.4, and for 0.4 seconds, our heart is in relaxation mode completely. And then the other heartbeat starts. The isovolumetric relaxation, during this time your ventricle relax and start to become expand, and the pressure come down in your ventricles. The atrial pressure now is greater than the ventricular pressure. Because of that, the semilunar valve become closed to prevent backflow of the blood from the arteries to the ventricles. AV valve remain closed at this time. When all valves are closed, blood neither enter nor leaves, and the time is called isovolumetric. I showed you this volume change. During this volume change, first we have end diastolic volume, which we have 130 milliliter of blood in the ventricles at the time of ventricular contraction, and when the blood is ejected to the aorta and pulmonary trunk, the amount of blood which remain in the ventricles are called end systolic volume. And the difference between end systolic and end diastolic is the stroke volume here, which is 70 milliliter for each of our arteries. And in this graph, you can see the mechanical event. Let me talk about this mechanical event in the next picture, which is bigger than this one. Yes, on this picture. In the first picture, you can see atrial contraction and ventricular filling. You see that your atria go to contraction, your ventricles are relaxed and accept the blood. You see that the AV valves, here the right AV valve and the left AV valves are open and the blood come down, but the semilunar valve of pulmonary trunk and the semilunar valve of aorta are closed. The ventricular pressure is less than atrial pressure, and also it's less than the aorta and pulmonary trunk. Then we have the next step. In the next step, our atria become relaxed and the ventricle start going to contraction. The atrial pressure is less than ventricular pressure, but the ventricular pressure now in this time is less than the pressure which we have in pulmonary trunk and aorta. During this time, all the valves are closed. The ventricle go to contraction, the blood start to circulate in our heart, in the ventricle, but it cannot go anywhere. We call it isovolumetric contraction. This blood can hit the AV valve when it wants to circulate, and it makes the first sound of the heart, which we call it loop sound. So the first sound of the heart is the of AV valve closure and hitting the blood from down to this AV valve on both sides of the heart. After that, the pressure in our ventricles go up. It's more than atrial pressure, and also it's more than the aorta and pulmonary trunk. This pressure can open this semilunar valve, and the blood is ejected to pulmonary trunk and aorta. I want to talk about the closure of AV valve a little bit for you. Look at here. I hope you remember that the AV valve are connected to chorda tendini, and chorda tendini are connected to papillary muscle. When our ventricles want to go to contraction, the first part which become contracted is the papillary muscle. When the papillary muscle become contracted, they can make the chorda tendini taut, and then the valve become closed. So it's about this AV valve closure. After the ventricular ejection, we have isovolumetric relaxation. The blood goes to pulmonary trunk and aorta, as you see here. This amount of blood is called a stroke volume. And we have the amount of blood which remain in the ventricle, and we call it ESV, or end systolic volume. In this time, the AV valve is closed, as you see here. The semilunar valve are closed, and you have a small amount of blood in your ventricle. We call it isovolumetric relaxation. Your ventricle is relaxed, all the valves are closed, and the blood cannot go anywhere. Isovolumetric relaxation. And then the pressure in the pressure of the blood in the atria increase, because we have returning back of the blood from the superior vena cava, inferior vena cava, coronary sinus, and also the pulmonary veins. The pressure in the atria increase, and they go to contraction again, and they send their blood down, and the next cycle of our heart starts. But before this next cycle, you can see that your atria and ventricle, both of them are in relaxation. The atria receive the blood, and it send the blood gradually to ventricles. So here you can see the atrial relaxation and ventricular feeling. In this time, all of your chambers are relaxed. The ventricular pressure is less than the atrial pressure and arterial trunk pressure, and the semilunar valve are closed and the AV valve are open. Pay attention, when we have ejection here, when we have a ventricular ejection, the blood goes to pulmonary trunk and aorta. Then the pressure in our ventricle come down, and this blood like to come back again to the ventricle. When it wants to come back, the semilunar valve become closed. This closure can make the second sound of the heart, which is the dop sound. So you have a sound which is loop dop, loop dop. The loop sound is louder and longer. It's due to AV valve closure, and dub sound is shorter and less loud, and it's the closure of semilunar valve. And we have a term which we call it ventricular balance. The amount of blood which are pumped by left and right ventricle should be the same. So the stroke volume for right ventricle and left ventricle, both of them should be 70 milliliter. Although we have a stronger and thicker wall in the left side, in the left ventricle, but the left side can make more pressure on the blood to send it to all parts of our body. And this amount should be the same. If we don't have the same ejection, then we have a problem which we call it edema. Edema or swelling can take place, and I will talk about systemic edema and pulmonary edema later for you. So here you can see all the events which we have in our heart. The first one is the green part. The green part is the atrial contraction and the ventricular filling. As you see here, the atria go to depolarization and we have P wave. Then we have atrial contraction, which you can see it here. The atria go to contraction and send the blood to the ventricle through the AV valve. The AV valves are open and the semilunar valve are closed. And in the next picture, in this green part, you can see that the ventricular pressure, which you can see it by the blue line, is less than the atrial pressure, which is the green line. This is the blue line and this is the green line. So the ventricular pressure is less than the atrial pressure. And also the pressure which we have in the aorta, as you see here, which is in red color. And the volume of the blood here, you see that the ventricular blood volume starts to increase a little bit here. Then you have the next step, which is the blue part here. The blue part can show us isovolumetric contraction. The ventricular depolarization take place in the blue part, and you can see QRS complex in the ECG. In the next picture, in this part, you see that the ventricle go to contraction. And I told you that the first part is the papillary muscle which go to contraction. They pull the chorda tendini. The chorda tendini become taut and the AV valve are closed. At this time, the semilunar valve are closed too, and we have isovolumetric contraction. And in the next picture, in the blue part, you see that the ventricular pressure, which is the blue line, starts to increase. It starts to increase and it becomes more than the atrial pressure, which is the green line. But it's somehow first it's less and then it becomes more than atrial pressure. And here in this blue part, you see that the ventricular blood volume remain the same, isovolumetric relaxation. After that, we have the yellow part. The yellow part is called ventricular ejection. The ventricular plateau phase is here. You see that we don't have any electrical changes here. This is the plateau of repolarization and contraction. Our ventricle remaining in contraction. And when the ventricle contracting, the atria, as you see here, are relaxed and the ventricles go to contraction. As you see here, the AV valves are closed and the semilunar valve become open due to the pressure of the blood. As you see here, the pressure of the blood in the ventricle is more than the pressure of the blood in the aorta, so the blood is ejected to the aorta. And here you can see the volume of the blood. As you see here, the volume of the blood in the ventricle starts to decrease and decrease. This amount which decrease is the stroke volume which we have. And then again, here we have the orange part. The orange part is isovolumetric relaxation. The ventricles, as you see here, go to repolarization, and then we don't have any electrical activity here. The ventricle is relaxed. The AV valve and the SL valve, both of them are closed, and the ventricular pressure become, let me show you this picture. The ventricular pressure is less than the pressure which we have in the aorta, and the volume of the blood remain the same here because the valves are closed, and we call this part isovolumetric relaxation. And the last part is the purple part. This is the atrial relaxation and ventricular filling. We don't have any electrical activity, as you see here. The ventricles become relaxed and the AV valve become open. When the ventricle become relaxed, again, the first part is the papillary muscle. When the papillary muscle relax, the chordae tendineae become slack and the AV valves become open, and the blood can easily come down from atria to the ventricle. The ventricular pressure at this time is less than the atrial pressure, and the amount of blood in the ventricle starts to increase. And after that, we have the next cycle. In this time, you should know which heart valves are open during ventricular ejection, and if cardiac muscle become weak, would end systolic volume increase or decrease? The next part is a term which we call it cardiac output. The cardiac output is the amount of blood pumped by a single ventricle in 1 minute. So each ventricle in 1 minute. We call it cardiac output. And the unit of this cardiac output is liter per each minute. And the cardiac output can show the effectiveness of our cardiovascular system. When you do exercise, your cardiac output should increase because your body needs more oxygen and more nutrient. So we need more heart rate here, and also more stroke volume at this time. And when we want to measure the cardiac output, you can see that the cardiac output is equal to heart rate times stroke volume. If our heart rate is 75 beat per each minute and the stroke volume is 70 milliliter per each beat, then our cardiac output become, let me type it here for you, become 520 milliliter per minute. And then we can convert this milliliter to liter by dividing it, with 1000. So you can use either of these two, 50 to 50 milliliter per each minute, or 5.25 liter per each minute. The total volume of the blood in our body is approximately 5 liter. Thus, with a cardiac output of approximately 5 liter per minute, the total blood volume is pumped through both the pulmonary circulation and systemic circulation every minute. And during the day, we have moving of more than 7,000 liters of the blood in our body. We should maintain the resting cardiac output. The ability to maintain the normal resting cardiac output is the function of both heart rate and the stroke volume, and the value of one influences the value of the other. For example, the individuals with smaller hearts can produce a smaller stroke volume. Consequently, the resting heart rate must be higher to maintain the normal resting cardiac output. So, as you know that the cardiac output is equal to a stroke volume times heart rate. So when the stroke volume decrease due to the smaller heart, our heart rate should increase. So a stroke volume come down. Instead of that, the heart rate should go up to keep our cardiac output constant. And individuals with larger heart have larger stroke volume. So when their stroke volume increase, their heart rate go down to maintain again the cardiac output in the normal range. So the athletes have larger heart and a stronger heart, their stroke volume is more, so their heart rate is less. And the women and the children have a smaller heart, their stroke volume is less, so their heart rate should go up to maintain a resting cardiac output. The next term which we have is a cardiac reserve. This is the capacity to increase cardiac output above the resting level. When we subtract the cardiac output at rest from the cardiac output during the exercise, we can measure and we can have our cardiac reserve. Cardiac reserve can accelerate during exercise, and at this time our stroke volume is increasing too. The cardiac reserve is a measure of the level and duration of physical effort in which an individual can engage. Cardiac output may be increased by about fourfold in a healthy, non-athletic individual, and up to sevenfold in highly trained athletes. In comparison, individuals with a weakened heart may have little cardiac reserve and thus experience limitation when they are in stress or during exercise. So the cardiac reserve is an increase in cardiac output about its level at rest. An increase in both heart rate and the stroke volume can result in an increase in cardiac output. During physical exercise, heart rate can be increased more than 170 beats per each minute, and a stroke volume can increase from 70 to 100 milliliter. So you see that our heart has this capacity to increase both the power of contraction to make more stroke volume and also make more heart rate at the time of sympathetic stimulation. And then we have a problem which we call it systemic or pulmonary edema. I told you that the ventricular ejection and the stroke volume should be the same for both ventricles. If they are not the same, we have edema or swelling. We have two types of edema. One of them is called systemic edema, may occur when our right ventricle is impaired and has problem, more blood remaining in our systemic circulation, and it the blood can go in the interstitial fluid and make swelling. And the other one is the pulmonary edema. It happens when our left ventricle has problem, more blood remaining in the pulmonary circulation, and it can make swelling of the lung. When our lung becomes swollen, then we have breathing difficulties and the gas exchange cannot happen properly. We have different factors which can work on our heart rate. These factors are called chronotropic agent or chronotropic factor. So the chronotropic factors are the factors which can work on our heart rate. Some of them are positive, they can increase the heart rate, and some of them are negative and they can decrease the heart rate. So the chronotropic agent can alter the activity of our nodal cell, SA node or AV node. They often work by our autonomic nervous system or different hormones. The positive chronotropic agent can increase our heart rate. One of the most important positive chronotropic agents is the sympathetic nerve stimulation. Let me talk about it on this picture. When the sympathetic stimulation happen in our body, we have release of epinephrine or norepinephrine from the axon terminal or from the medulla of the adrenal gland. The one which is secreted from the nerve terminal is called neurotransmitter, and the one which is secreted by the medulla is called hormone. But both of them are the same. And as you see here, the sympathetic axon can release norepinephrine and epinephrine from, and also we have secretion from the adrenal medulla, which act as the positive chronotropic agent to increase the rate. As you see here, the norepinephrine and epinephrine can attach to their own receptor on the nodal cell. This is the cell in the SA node or the AV node. When they sit here, this combination of neurotransmitter and the receptor can activate the G protein. When the G protein become activated, it activates the other messenger in our cells, and all of them has one result. The result is the opening of calcium channels in our nodal cells. When the calcium comes to our cell, it can make more contraction in our cell. You know that the calcium ion can attach to the TNC of troponin, and then we have more contraction. And different hormones can work the same as epinephrine and norepinephrine, like our thyroid hormone, caffeine, nicotine, and cocaine. All of them are positive chronotropic agents. All of them can increase the heart rate, and you can see the list of positive chronotropic agents here: thyroid hormone, caffeine, nicotine, and cocaine. The negative chronotropic agent can decrease the heart rate, and the parasympathetic activity is one of the negative chronotropic agents. The parasympathetic axon can release acetylcholine on the nodal cell, and acetylcholine bind to M2 muscarinic receptor, and this receptor work with potassium ion. The potassium channels become open, potassium ion leave out of our cell, and inside the cell become more negative. When it become more negative, it needs longer time to reach to the threshold level, so our heart rate decrease. And some beta blocker agent which can interfere with the function of epinephrine and can do the same problem. And we use these agents when we want to treat the high blood pressure. The other factors are inotropic agents. The inotropic agent can change the stroke volume. They work on the contractility of our heart, the force of contraction. The primary external factor which can increase and decrease the heart rate is autonomic innervation and also the hormones. These factors can also change the stroke volume too. Inotropic agent can change the contractility of the heart and the force of contraction. An increase or decrease in the force of contraction is generally due to the change to availability of calcium ion in the sarcoplasm. Changes in calcium ion concentration can change the number of cross bridge which form in the sarcomere, and thus it can change the force of contraction. A positive inotropic agent can increase the calcium ion concentration and which result in formation of additional cross bridge. Positive inotropic agent includes norepinephrine that is released from the sympathetic neuron and epinephrine and norepinephrine from the adrenal medulla. These ligands can bind with beta-1 adrenergic receptor to cause an increase in calcium level within the cardiac muscle cell. Thyroid hormone is the other inotropic agent, a positive inotropic agent, which can increase the contraction of our heart and the stroke volume. Some drugs like digitalis can work the same. And the negative inotropic agent can decrease availability of calcium, and thus they can decrease the power of contraction and the stroke volume. Some electrolyte imbalances can make it, like when the potassium ion or hydrogen ion increase in our body and in interstitial fluid. They have competition with calcium ion. They don't let calcium ion to come into the cell, so the power of contraction come down. And certain drugs like calcium channel blockers can block, and then the contraction of our heart decrease. Most of the times we use this calcium channel blocker when we want to treat the high blood pressure. And for regulation of the stroke volume, you need to know 3 factors. One of these factors is called preload, one of them is called contractility, and the other one is called afterload. The preload is a stretch of the heart wall due to the load to which a cardiac muscle is subjected before shortening. It means that when our heart wants to go to contraction, we need to stretch the ventricles. The ventricles become more stretched by having more and more blood, and this stretching is called preload. When our preload increase, then our stroke volume increase too. In other words, preload is the heart muscle wall stretch just before contraction. We have a direct relationship between the venous return, the blood which return from the veins, superior vena cava, inferior vena cava, and coronary sinus, and the stroke volume. So they are related to each other. The other one is the contractility, forcefulness of of contraction influenced by autonomic nervous system, hormones, and calcium ion concentration. When we have sympathetic activation, when we have release of epinephrine and norepinephrine from adrenal medulla, and when the amount of calcium ion increase in our body, so the contraction of the heart increase. When the power of contraction increase, goes up. And the last factor is called afterload. The afterload is the resistance in arteries to the ejection of the blood by the ventricle, and it represents the pressure that must be exceeded before the blood is ejected from the chamber. So the pressure which we need to eject the blood from the ventricle to the arteries is called afterload. And we have a law which we call it Frank-Starling law of the heart. Greater stretch of ventricular muscle fiber during diastole lead to generate more force to contraction during systole. And when more blood return to our heart, which we call it venous return, more blood can ejected from the heart. So we call it Frank-Starling law. In this picture, you can see the relationship between EDV, ESV, and the stroke volume. Here, you see that the stroke volume is dependent on the venous return. So when the venous return increase, when the amount of blood which come down to the atria increase, then the stroke volume goes up. The other one is the inotropic agent. The inotropic agent are the agent which can make more contraction in our heart. So when we have inotropic agent, we have more contraction of the ventricle and the stroke volume increase. And the other one is the afterload, the resistance in the arteries which push our ventricles to make more pressure on the blood. So when all of them increase, then our stroke volume goes up. And here you see that the end-diastolic volume is the volume of the blood in the ventricle at the end of rest, and the end-systolic volume is the volume of the ventricle immediately after contraction, and the stroke volume is the subtraction of EDV and ESV. So it's equal to EDV minus ESV, and then we have our stroke volume. So you see that all of them are related to each other. And we have some factors which can affect our stroke volume. One of these factors which are very important is our venous return. One of them is inotropic agent, and the other one is the afterload. Here I want to talk about the venous return. The venous return is the volume of the blood returned to heart per unit of time. When the venous return increase, it can increase the stroke volume for us. When the venous return increase, it can increase a stretch of heart wall. So it can increase the preload, which result in greater overlap of thick and thin filament in our myocardium of the heart, and we have additional cross bridging, and the ventricle can contract more and more, and the stroke volume goes up. The inotropic agent, as you see here, and we talked about it before, some positive inotropic agent can work on our stroke volume. They can increase calcium level in the sarcoplasm. So when we have more calcium level in the sarcoplasm, then the calcium and troponin can attach to each other more, and then we have more power of contraction. Additional cross bridge form, and the ventricle contract with a greater force, and the stroke volume again increase. And the other one is the afterload. The afterload is the resistance of the arteries. The atherosclerosis, which is the deep cholesterol plaque on the inner lining of our blood vessels and arteries is typically the only factor when we age. Arteries become more narrow in their diameter, so their resistance increase, and then our stroke volume come down. So the afterload is the resistance. It can decrease our stroke volume, but the inotropic agent and the venous return can increase it. We have two terms which you need to know about them. One of them is bradycardia and one of them is tachycardia. The bradycardia is a persistently low resting heart rate in adult. When the heart rate is below 60 beats per each minute, we call it bradycardia. It's very normal in highly trained athletes, and it's abnormal due to hypothyroidism, electrolyte imbalance, and congestive heart failure. And tachycardia happen when the heart rate increase more than 100 beats per each minute, and it's caused by heart disease, fever, and anxiety. And the regulation of our heart center in the medulla oblongata is the origin of nervous system which can regulate our heart rate. It can receive different inputs from our proprioceptors, chemoreceptors, and baroreceptors. We have some input from limbic system and also the cerebral cortex of our heart, and we have autonomic regulation too. The chemicals can regulate our heart rate, like hormones, epinephrine and norepinephrine, and thyroid hormone. We have some cations when we have imbalance of sodium ion, potassium, hydrogen, and calcium. All of them can change our heart rate. And the other factors like age, gender, physical fitness, and the body temperature, all of them can affect our heart rate. You know that by aging, our heart rate decrease. The heart rate in female is is more than male because their heart is smaller. The physical fit person has a lower heart rate than the normal person. And when the body temperature increase, for example, during fever, our heart rate increase too. Here you can see the information, the input of our medulla. We have from higher brain centers like cortex, the limbic system which work with our emotion, and also our hypothalamus. And we have receiving information from proprioceptors, baroreceptors, and chemoreceptors. All of them can go to the medulla. Sometimes our cardio acceleratory center become activated, and sometimes our cardio inhibitory center. If our cardio acceleratory center increase its function, both the heart rate and the power of contraction increase. So both heart rate and the stroke volume goes up and our cardiac output increase. But if our cardio inhibitory center becomes stimulated, which is the stimulation of parasympathetic fibers, only our heart rate decrease. The parasympathetic fibers cannot work on the power of contraction. So this is the autonomic regulation of our heart rate. And in this time, you need to know the answers of this question. How do positive chronotropic factor can affect our cardiac output? What is the example of negative inotropic agent? How does the heart respond to increase to the venous return? And which type of heart cell is influenced by chronotropic agent? Nodal cell or cardiac muscle cell? Let me know if you have any question in this part.